first of all, kidney cancer is quite a heterogeneous solid tumor where we don't really have good biomarkers to help us select therapies. And we do have the IMDC, but I don't think that was intended to be predictive. It is more of a prognostic categorization, right? I mean, we do have some emerging data on angiogenic signatures, RNA signatures, and immune-inflamed signatures that might help us select whether we do dual immunotherapy combinations in the frontline setting versus immunotherapy plus tyrosine kinase inhibitors or IO-TKI. We do have, I would say, 4 major regimens that we have FDA approved in this country, and that's ipi-nivo. We have the longest follow-up with that regimen with 8-year follow-up now, and that's a pure IO combination. And then we have 3 IO-TKI combinations that we have at our disposal as well. And I think the big question for many oncologists is how do we decide when to use what? And I think to simplify it the most is when do you use IO-TKI? When do I think I need to use the tyrosine kinase inhibitor in a patient? And I would say the 3 regimens, whether it's pembrolizumab and axitinib, cabozantinib and nivolumab, and lenvatinib and pembrolizumab, there's going to be more similarities than differences in the efficacy, in the tolerability. If you look at the tornado plots for tolerability, it's a family class effect with TKIs. You're going to have the similar hand-foot syndromes, the taste changes, the dysphonia, and all of the fatigue that comes along with it. And with all of those TKIs, they're going to have a cumulative effect as far as building up in your system and probably needing some breaks here and there to kind of wash out the toxicity. But the one thing that I think is clear is that, the IO-TKI regimens, where we're seeing longer follow-up, while there is a significant progression-free survival benefit and higher overall response rates compared to IO-IO, we're not so sure that these regimens are really extending overall survival compared to, say, the comparator arms of these trials were sunitinib, right? And we're not even using sunitinib anymore. So across all these favorable, intermediate, and poor risks, there's clearly activity on all this population, but are we actually helping patients live longer without toxicity and the durability that we're seeing from IO-IO, from ipi-nivo?